53-year-old female, uh, uh, has Medicaid insurance, Aetna Better Health of West Virginia. She came in just for a regular follow-up, and she has a previous history of hepatitis C and previously diagnosed with rheumatoid arthritis. But on physical exam, no acute distress, normal ambulation. She is obese, has good judgment. Everything was pretty normal aside from she did have mild bilateral swelling of her proximal interphalangeal joints, no other knee or ankle swelling. And then I included the labs from the initial visit and her infectious disease visit from in the past, which I'll go into. So she's a 53-year-old presenting for the clinic for a wellness visit. Initial visit was in 2019 to establish care, and she complained of bilateral hand, shoulder, and foot pain at the time. She had reported that formerly using IV drug use in the past, but had been clean since 2016. She'd been previously diagnosed by a provider with hepatitis B and C in the past, but she never received treatment and didn't follow up. She reports no history of HIV at the time of this visit. Labs from her visit in 2019 showed active hepatitis C infection, viral load of 5.42 million, along with the elevated ESR and rheumatoid factor, because there was a suspicion of possible rheumatoid arthritis. So diagnosed her with rheumatoid arthritis at the time, referred her to ID for management of active hepatitis C, and told to use ibuprofen alone for the rheumatoid arthritis until after seeing ID for the treatment of her active hepatitis C. She went and saw infectious disease in July of 2020, found to have genotype 3, completed an 8-week regimen of Mavorite, and then followed up with her PCP after completion of the Mavorite regimen, started on hydroxychloroquine for rheumatoid arthritis. Came in December 2021, complains that her arthritis was worsening. Her labs at the time showed undetectable hepatitis C viral load. Her rheumatoid factor had increased to 270 from her previous visit, which was 125 originally back in 2019. Discontinued the hydroxychloroquine therapy and then started her on the methotrexate. And then so today at the current visit, she states that her rheumatoid arthritis is well controlled on the methotrexate. Still no substance use since 2019 and no concern for virus reactivation. Comorbidities, so morbid obesity, overactive bladder, generalized anxiety, history of substance use, hepatitis C and B, and then rheumatoid arthritis diagnosed at the initial visit. So whenever she came in for the visit back in 2019, she was only taking ibuprofen and CBD oil. The treatment regimen for hepatitis C was Mavorite for 8 weeks in 2020 and showed that it cleared the viral load to be undetectable. Current medications, bupropion, fluoxetine, folic acid, ibuprofen, loratadine, methotrexate, has the Narcan, oxybutynin, and Victoza for weight loss. And then down to her vaccinations and immunity. So she was did not have the hepatitis A antibody. She does show immunity to hepatitis B because of previous infection. So she got her core antibody was positive, but surface antigen was negative at the time. Height 62 inches, weight 201. So lab results. So down here, I won't read through all of it, just kind of hitting on the ones that we were like maybe looking at. So our ALT and AST were elevated. So ALT was 96, AST 97. These are all from the October 2019 lab draw. APRI 0.962, child circuit likely class A. The HIV antibody was negative again whenever they tested it in 2020. Hepatitis C genotype, this is from infectious disease, genotype 3. Our viral load at the time was 5.24 million back in 2019. And then when ID saw her, she had a serum fibrosis biomarker of 0.42, which was in the F1 to F2 on the stage. Some other labs that I brought up here that had just reviewing in the past, ESR is 46, rheumatoid factor 125 at the initial visit. Back in 2021, her hepatitis C quantitative was not detectable. rheumatoid factor 270, so that had increased. And then the necroinflammatory activity score at the time of seeing infectious disease was 0.63, which was grade 3, which was the highest that I saw on the score of the report. So just some of the points that I wanted to bring up was kind of seeing if the correct choice was made to treat the rheumatoid arthritis with anything besides ibuprofen until waiting to clear the active hepatitis C. Any suggestions for alternative treatments of rheumatoid arthritis or extra precautions for monitoring virus reactivation while on methotrexate? And then also want to bring up, because methotrexate is known to cause hepatotoxicity, or like known to cause elevations in ALT, AST, and like kind of like monitoring for that whenever she's had the previous infections of hepatitis. And then also something else that I was looking up and while kind of finding out topics about this. So distinguishing between rheumatoid arthritis and hepatitis C associated arthritis, aside from just the anti-CCP, because that was one of the labs that I saw that that didn't get drawn before. And I think that would have been helpful for distinguishing, because I was really unaware that you can see a very similar kind of like hepatitis C associated arthritis that's pretty much looks identical, aside from I think that rheumatoid arthritis, you can see more erosions and kind of longer lasting effects, whereas the hepatitis C associated arthritis usually tends to be not as long of lasting and you don't typically see the erosions. So thank you. Any questions?
Thank you so much. That was excellent. Really appreciate that. You turned in that case, David, and you did a great job presenting. Does anybody have any clarifying questions for David?
Thanks, David. This is Kaylee. I wanted to just ask a quick question about the Hep B. Did you have a surface antibody as well on this patient?
I did not see a surface antibody in the charts whenever we were reviewing, because they use down at the clinic, they use I'm trying to think of what the Athena for the database, and I'm not familiar with that, so I had to like be with my attending the whole time looking through the labs, and she was having a request a lot of these to be sent back over. So it's these were pretty much all of the labs that we had sent over whenever we requested those. So I didn't get to see a surface antibody. All we saw was the surface antigen was negative, and then showed the core antibody was positive.
Gotcha. Thank you so much. Yeah, I think you did great research with this. I think you touched on all the points that I would have really brought up with this case, but I'll just kind of go through each of your questions and try to answer the best that I can. So I'm not a rheumatologist, obviously. So you may have different perspective from their standpoint, but I'll kind of go through my discussions with rheumatology here at WVU and what our approaches have been with similar cases. So was it correct to wait until treating the RA until after clearing the HCV? Like you said, it's really hard to distinguish between the two many times. And so actually with a lot of viral infections, there can be viral arthritis. So I would say from an ID standpoint, unless it were an acute infection, from our standpoint, no real need to delay treatment of the arthritis prior to treating the Hep C. Now with rheumatology, they do tend to be a little bit more prudent in wanting the Hep C to be addressed first. But that really comes down to, I think, partially to that kind of unclear diagnostics in a fair amount of cases. You can have all kinds of diagnostic testing that's confusing even in the absence of Hep C. So sometimes their rheumatoid factor is negative, sometimes their rheumatoid factor is positive, and the CCP, anti-CCP is negative. But I think overall their approach is that they want the Hep C addressed first, mainly to just kind of rule that out as being the underlying etiology, and then tackling the RA afterwards. But like you said, rheumatoid factor, that can be positive even without any symptoms in like 40 to 60% of individuals that have Hep C without RA. So, I mean, if we just tested rheumatoid factor for everybody, all of our Hep C patients, we'd still find that, high value, and it doesn't always mean anything. The anti-CCP is very helpful and kind of, we don't really see that very often with Hep C associated arthritis. X-rays, like you said, you don't really typically see erosive or deformities with Hep C associated arthritis. And for the most part, Hep C arthritis is overall pretty rare. We tend to see more arthralgias and myalgias, but not really true arthritis. So kind of in that bucket, it's rare to begin with. With alternatives, so or precautions with monitoring for viral reactivation, your second question, while on methotrexate, it depends on where you're at in the Hep C treatment. So again, if you have a concomitant diagnosis of Hep C and RA, they may be started initially on like Plaquenil or like sulfasalazine or along with NSAIDs, and then methotrexate may be, a little bit more down the line just because of its independent potential for hepatotoxicities. If you don't really have that clear RA diagnosis and you're not, might be the Hep C arthritis, then probably not going with a methotrexate first. But all in all, I mean, you're really going to be hopefully treating the Hep C in short order. So it's not something you have to really be too concerned about. The reason I was asking about the Hep B surface antibody, and I'd still either try to draw this on this patient or find those prior results, especially if she's on methotrexate, is we don't tend to worry about Hep C reactivation or a worsening hepatotoxicity with Hep C, but Hep B, even with natural infection, there is that possibility, not just if it's active Hep B, but if there's this isolated core positivity to where they've had natural infection, but they're not actually immune. So that's certainly something that you'd want to look into further. Other agents we tend to worry a lot more about with Hep B reactivation would be like rituximab, and that's even if they have that immune body response. But that's something I would still find out in this case. And then, tips for distinguishing between RA and HCV associated arthritis, aside from what you said, like I said, a lot of times it's part of the history taking. If it's kind of more of like an acute arthritis, could be more from a viral perspective. You don't usually see arthritis longer than 6 weeks with these viral infectious processes, more arthralgias. The anti-CCP, the X-rays. You could check, just because we see Hep C so commonly associated with cryoglobulinemia, you could check serum cryoglobulins as well. But overall, I think the management approach is going to be very similar. For quality of life, you're still going to treat the symptoms. I think with starting off with NSAIDs is reasonable, just like you guys did, Plaquenil, and then escalating the therapy once the Hep C is treated if there's no response. I think that was very well managed. Did I answer everything, or was I clear enough? Because I feel like I ramble sometimes.
Perfect. Yeah, that was awesome. Thank you so much. That definitely answered all of the questions that I had about that. Because
I appreciate you presenting that, because a lot of times we kind of, when people are presenting cases, we're kind of like, oh yeah, extrahepatic manifestation, and we just kind of leave it there. But this gave us an opportunity to actually, you presented a case and showed the management of this arthritis and the Hep C, and so we kind of have a little bit more opportunity to go into a more detailed discussion. So I appreciate that. Thanks so much for presenting it. You rock.
Yeah, thank you so much.
Thank you. Thank you so much, Kaylee, and thank you, David. Does anybody else have any comments or questions before we move on to the next case? Give it that good old echo pause. I think we're good. All right, Gary, are you ready?
Yes,
All right, we'll go ahead and begin. Give me one moment, please.
mine are pretty straightforward.
We'll start with this case of the 51-year-old male.
All right, this
Sorry
is
to
a 51-year-old male. Both my kids are actually new patients to me. He has a history of IV drug use and intranasal drug use. He started about 20 years ago. He stopped everything 8 years ago. He did attend rehab, but he's not currently going to any meetings. His exam was pretty much normal. His ultrasound showed moderate fatty liver. Elastography was F2. He has depression, anxiety, hypertension, and PTSD. He's currently on amlodipine, Suboxone, Wellbutrin, gabapentin, and vitamin D. He is immune to hepatitis A, I'm assuming from exposure. His BMI is 27.5. Overall, his labs, his creat was 0.67 and AST was 43. His APRI was 1.4, child was 5A, MELD score was 8. Vitamin D was 23. His genotype is 2, viral load was 2.4 million. His fibrosis biomarker was F3. He is not immune to Hep B, and I've ordered those tests, the vaccine to be started. I don't think there's any interactions with the medications. Would Maverick be the best choice?
Thank you so much, Gary. Does anybody have any clarifying questions?
Hey, Gary, John, quick question, man. Did any of the imaging modalities comment on the morphology of the liver? Did anything suggest that this was a cirrhotic liver? I know that not the elastography F score per se, but more if he's had a CAT scan or an ultrasound, did they comment on it being a tiny little lobulated liver or anything like that?
Give me 1 second. Let me try to pull up the image.
And the rationale, the reason I'm asking is his platelet count surprisingly low, kind of disturbingly low. I didn't look at his transaminases. They're okay. Like, yeah, the platelet count is worrisome. Yeah.
And sometimes, Gary, that'll improve just with the Hep C treatment. The Hep C alone can cause that thrombocytopenia, but more concerning, especially he's got the F3 fibrosis marker with the low platelets. I mean, I would probably trend your CBC about a month into treatment just to see if it's improving substantially.
Yeah.
And then check your hepatic panel too. Maverick would be fine, but I'd still recommend doing HCC surveillance every 6 months on this guy.
His ultrasound just says the liver demonstrates increased echo architecture. There are no focal lesions identified.
Gotcha. Okay, so there is some fibrosis there.
Yeah.
And sometimes the elastography value, which again, that's why we try to use as many modalities as we can for fibrosis assessment. Sometimes it'll say F2, and then the report or the imaging will actually show, nodular contour or cirrhotic findings. And so, in this guy, I would be more prudent with monitoring him and keep doing that HCC surveillance long term. But you may see improvement in his counts with the treatment alone.
Yeah, for sure. Like Kaylee mentioned, the other mechanism besides cirrhosis and sequestration is ITP. And that's the hard one to make. How old is this guy? 51. So he could have cirrhosis at this point. But yeah, the other mechanism is autoimmune, and you're going to fix that as you shut down his immune activation by treating his Hep C. That would improve. So anyway, yep. The punchline is, despite that saying F2, his APRI and fibrosis biomarkers say long-term HCC screening.
Right.
Great, thank you so very much. Are there any further questions on that case, Gary, before the other?
No.
Perfect. Okay, give me 1 second. All right, go ahead. This is a 42-year-old male.
So this is a 42-year-old male. He started IV drug use and opioid use about 15 years ago. He's been clean for 10 years. He was in rehab. That's when he was diagnosed. He never sought treatment. He has been clean since rehab. He doesn't use anything currently. His exam was normal. His ultrasound showed the beginnings of fatty liver. Elastography was F2. Comorbidities is GERD. He's on omeprazole. He is immune to hepatitis A, not B. His BMI is 33.8. His APRI was 0.2, MELD was 6. Genotype is 1A, viral load is 1.17, and serum fibrosis was F0 to F1. The rest of his labs, I do believe, are okay. Yeah, his platelets were 266, iron R is normal, ALT, AST was normal. And then we started the Hep B vaccine.
Thank you so much. Any comments or questions first? All right, we can go into the post recommendations. Thank you.
Hey, Gary, I agree. I think Maverick would be for 8 weeks for this guy, and the last guy would be appropriate for this gentleman. The only thing I maybe, could consider is with his insurance, if it's not a preferred agent, then you may have to go with Epclusa for 12. The issue with that's going to be the omeprazole. And so, certainly try to get the Maverick approved. If you have to go with the Epclusa for 12 weeks instead because of payer preferences, then you'd need to hold the omeprazole or preferably switch it to like a Pepcid.
Okay.
And administer it with the Epclusa. But Maverick, there's no drug interactions and that should be fine.
Okay.
Thank you. Any further questions, Gary?
No, thank you guys so much.
Excellent. Thank you so much. Really appreciate you submitting the cases. All right, Robin, are you presenting this case? All right, perfect. I'll go ahead and pull it up. Go ahead.
No, I'm gonna try to see your screen. Let me gotta move some stuff here. Okay, I'm sorry. I'm trying to see your screen, but I can't. It's only showing me everybody's faces. So give me just a
Oh,
second.
you're fine.
Well, I'm assuming that you have the same paper pulled up as the paper that I have printed. So I'm going to use this.
That's fine. The 25-year-old male, right? It's case 3280. All right, perfect.
This is actually probably going to be one of the simplest cases, I think, today. This fella is been clean since January of 2022. He used meth and heroin in the past, IV drug use. So he has schizophrenia, but he's being cared for at the facility where I work at Southern Highlands. So he's seeing a site provider here, and he's only on olanzapine. And right now he's stable and he's been compliant with his medications. He's working full time now. I think he has himself together and he's getting regular care. So he was immune to hepatitis A and B. He is BMI is 26.6. Relevant labs for him, his platelets were 229. Creatinine 0.81. His iron R was 1. The liver enzymes that are reported there are incorrect. He actually, his liver enzymes were actually 63 and 43. So that changed his AFRI score that you have there to 0.5, which, is probably better than what it would have been with the other results. So, I don't think his AFRI shows that he's got significant problems. His child Q was class A, and his MELD score was only 6. His AFP was 3.3. HIV was negative, and he has a viral load of 4,200,000. His serum fibrosis marker was 0.54, makes him an F2, and he has genotype 1A. I did, since it has some fibrosis, the F2, I just went ahead and got an ultrasound, and the ultrasound was relatively, it was normal. It had some hepatic steatosis. Everything else was normal on. So he doesn't have any contraindications as far as the medications. So Maverick is going to be my choice for him, unless you all have other suggestions. Oh, I don't have a vitamin D on him. For some reason, I let that fall through the cracks. So I do plan on getting him in here and getting a vitamin D, because usually if I'm treating for Hep C, I've got him on vitamin D. I'll always like. That's all I have.
Thank you so much, Robin. Does anybody have any questions for Robin before we go to the recommendations?
Hey, Robin, do you know if he was ever, or how long he's been diagnosed, or if he has any negative testing on file?
He don't have a clue when he got it, so I don't have any of that.
Okay, so you guys diagnosed him when he came in?
Yeah, we did.
Oh, okay. Just because his liver enzymes, and I apologize because the audio on mine was cutting it in and out a little bit, but you said that his enzymes went from like the 300s down to like 6.
That actually wasn't his. That was recorded incorrectly.
Oh, okay.
Happened was had seen psych, and when he sees, they always do a CMP, and I think his liver enzymes there. With his history, they suggested that he come and see me, and so we ended up doing testing and diagnosing.
Gotcha. Okay. That makes more sense. I was just trying to sift out if there was a possibility for an acute or recent infection. I know his sobriety date was a while, but just trying to sift that out. But okay. So with that being said, yeah, Maverick Freight sounds great.
Okay.
Great. Thank you so much. All right. John, are you ready?
Oh, I'm muted. Hey, it's going to be a 2 or 3 minute pause while I have to log out and get back into my context. I made a Frankenstein of a talk that can't be emailed. It's so giant. Isn't that all? Oh, don't worry. That's not all for today. It's like going to be spaced out over, I think, 3 times.
Excellent.
I will disappear for a minute and then be back.
Perfect. Thank you.
Well,
I was wondering about your
I really wish we had like some nice elevator music for you guys, or some tunes. I've thought about trying to do that, but it's a lot more work than it seems. I would have to play it on my phone, and I don't know if you'd like my selection.
You could sing, Elizabeth.
I used to sing.
Hum us a few bars.
It's been a while though. I don't know. I'd have to practice and then I'll get back to you guys. I was like a double major with music and science for a time.
You could do it.
Just so you know, I can't hear you, John, at all. P.S.
Hey, Elizabeth, can you hear me now?
Now I can hear you.
Yeah, I'm logged in both as Kaylee and myself, and I'm talking as Kaylee, which is interesting. But yeah, it's pretty fancy. But anyway, I've got this figured out. So the goal, can you see my stuff now? Is it showing up?
Yeah, if you want to make it a little bigger, yes, perfect.
There we go. So we have a goal in this sort of ECHO program to be attentive to the needs of our of everyone, hopefully. And our referral patients have keyed us into the fact that Lyme disease is a major problem right now, and there's a lot of input that we can potentially assist with. And I think this is a disease process that will be, the needs can be met with an ECHO project. And so what we're going to do is try to expand ECHO into including some Lyme cases as well. I have a 3-part didactic that will literally tell you everything I know about Lyme. And we're going to start out with about 20 minutes today, about 20, 25 minutes today. And it's a giant, overwhelmingly long PowerPoint, and I will do about 20 slides today. And this is sort of the outline. We'll get a little history, which matters. The interesting thing about taking care of Lyme patients is that there's a few parts. There's a lot of parallels with hepatitis C, believe it or not. It's one of the disease processes that I have regret on how I used to take care of patients that had Lyme versus how I currently take care of patients with Lyme. And it's the same thing when with hepatitis C. It's one of those disease processes. I look back 15 years of hepatitis C care, and yeah, our treatments are better, but I also learned a lot over the years that we communicate during our Hep C echo, and that's a lot of sort of giving credit and credibility to patients' symptoms. And that's a lot what I've learned with Lyme is this is a nasty disease. It is something that I want to teach, hopefully, empathy. I'm taking care of these patients, and the first and probably most important lesson of all of this is education of the patients. So patients come in with a lot of misinformation from Lyme, from things they've heard from neighbors, from what the internet's told them, and so on and so forth. And often in a 15-minute encounter, they don't receive satisfactory input to allow them to process what's going on. And all I do for Lyme patients in general is educate. That's my approach, is education. And in general, what that does is it is going to provide them some context to process their complaints, an understanding of the natural history and expectations for improvement. And it does allow them to avoid falling into any alternative medical practices that might be harmful. And so what I want to do is share over the next couple didactics, just my approach to Lyme and a little education. And I'm going to point out some of the slides I literally share with my patients, and we'll go from there. And as always, ask questions. I love your all's input, and go from there. So these are the ones I hope to hit today. History, talk about the tick, talk about the microbe, and some prevention. I literally do this part in about 3 or 4 minutes during a patient encounter, but I'm going to turn it into 15 minutes for you all. So history, obviously, this is the rheumatologist that described Lyme disease back in the late 70s. And initially the thought process, this was children with JRA, juvenile rheumatoid arthritis, but there were some epidemiologic clues that seemed like it wasn't. such as the time of the year, the clustered presentations. And the thought process was, man, maybe this is something different. Maybe this isn't just an autoimmune disease. Maybe this is an infectious process. A few years later, the microbe was isolated. So between the late 70s, they sort of were describing these patterns of illness. And then finally the spirochete was discovered a few years down the road. And it all fit that it was a tick-borne process. And I wish the fellow who discovered its name wasn't Willy Burgdorfer, or I wish his name was like Jones, so I could just be like Borrelia Jones, you know, or Smith, something easier. But they named it after this guy's cool last name. So anyway, that's the name, and it's gone from not even knowing what it is, not recognizing what it is, to being the most commonly recognized vector-borne disease in the U.S. And these numbers are woefully wrong. 30,000 cases a year reported this is admitted by the CDC. This is about the capture rate of acute hep C. So remember, for acute hep C, we say it's maybe 1 in 20 gets captured. Same for Lyme. We capture the minority of people, but in terms of recognized cases. But it's you know, for some reason, and I think the why on this, it's a very acceptable infectious disease to have, and because you get it via Americana, you get it mowing the lawn. You get it skinning a deer. You know, we've had a spirochete that can cause diffuse manifestations for decades, but it's for millennia, syphilis. But nobody's, you don't see Avril Lavigne on the front page of People being like, I had syphilis. People don't go there for that. It's because it's acceptable to get Lyme disease. In fact, it's kind of like, that's right. I get off my couch. I got Lyme disease. Here we are. So, but it's a problem. There's more and more of it. The tick is the oxoides that spreads it to people. But here's the thing I actually want you to conceptualize Lyme disease as. Lyme disease is a mouse disease. It's the mouse that's the problem. So the mouse is hanging out here. They cannot successfully clear Lyme from their bloodstream. So they just live with it. They're the reservoir. They're the spirochete reservoir. The poor tick is born uninfected and then gets infected after feeding on the mouse, and then sometimes up to chipmunk. By the way, there's a couple other small creatures that can't clear the spirochete on their own. Sometimes a squirrel, and then we are inadvertent hosts. We don't the spirochete doesn't want to end up in us, but the tick bites us usually at the nymph phase. Now, I'll talk about the role of deer, but they really just work as like a disease amplifier. Now, just know that the ticks are really small. The one that usually causes trouble is the nymph, and that's this one I'm circling over here. So the oxoides in general has this two-phase looking color to it. It's sort of brown and brown, but the rear end looks more orangish in real life. But you can't tell that variation in a nymph. In a nymph, it almost looks like they describe it as a poppy seed, and I think that's very accurate. For bad 40-year-old eyes, I can't even see the legs on them half the time. So it looks like a dot to me. And it's that nymph that tends to be the one that's most frequently infected with Borrelia burgdorferi and then passing it on to a person. I have zero faith in my own eye's ability to differentiate degree of engorgement. This gets a lot of play of trying to estimate the degree of engorgement of a tick. And there are actually measurements that you can do if you're a pathologist and have a dissecting microscope to try to estimate this. I have never successfully estimated this correctly, but just know the bigger and plumper it is, the longer it's been attached, okay? And the reason it matters is this statement right here. Of different tick-borne pathogens get passed from tick to human at different time frames. Some of the viruses that come from ticks get passed immediately, like immediately. A thing bites you and you could have a viral infection from a tick. But there's the other pathogens, Ehrlichia, rickettsiosis, babesia, they all come in a little bit slower. But the slowest of all seems to be this Borrelia burgdorferi. This takes a long time. A lot of the studies actually show it's more like 72 hours of attachment time. And you might say, how on earth can you have a tick attached to you for 72 hours? It's because they're so small. They're so tiny. You really don't see them. I had one, this is a gross story. It's gonna make y'all think I'm unhygienic, but I promise I wash my hands before every patient. Nonetheless, I had a spot right here on my hand that I thought was a scab. I thought I don't know. I thought I had just had a little scab there. And then it wasn't until about 5 days into it, I realized that scab had legs, and pulled it off. And I was like, darn it. I said, darn it. I didn't swear. And, but anyway, I sent it, and I'll talk about the service I sent it to get some information. So where Lyme is depends upon this oxoides ticks that carry it. And that's sort of an evolving paradigm. But one of the fascinating things is, look at this diagram. There's oxoides in more places than there is Lyme disease. And that's fascinating. And I'll talk more about that. But in general, the primary states are the Northeast, all the way down through Virginia now. This is the most recent map from 2017 I have from the CDC, but it's actually, West Virginia is now totally endemic. We are considered one of the endemic to hyper-endemic states. We're completely blue now. And it's really, it's the Minnesota, Wisconsin, or anywhere in the mid-Atlantic to New England, okay? And I like this map better because this really shows the high incidence states. Anywhere along there, you get an ixoides tick that bites you, it's considered highly likely that's going to pass on Borrelia burgdorferi to you. You know, and there's I met an entomologist, super cool guy named Eric, who works down in Charleston, and this is what he does for a living. It's really cool. The entomologist gave us about a 3-year head start warning that told us clinicians, you're going to start seeing Lyme. And we didn't see Lyme from about when I moved here in 2000 through 2010 to 12. We just didn't see it. We didn't have it. And if we saw it, it was either caught in New England and imported here or from the Great Lakes area. But what Eric et al. Do at Charleston is they go out and do these tick drags. They drag flannel clothing through like wooded areas, and they find these ticks. Remember, a tick can't fly, it can't jump, it doesn't land on you like from above. It does something called questing. It sits there on the end of either a leaf or a piece of vegetation or an underside of a leaf, and it has its arms out, and when it recognizes something warm or soft or exuding carbon dioxide going by, it clings onto it. And so you have to have contact. When they can get these ticks and calculate how many of them are oxoides and what percentage of the oxoides are infected. And it turns out they knew ahead of time that we started getting a lot more oxoides ticks, and a lot of our oxoides ticks had the spirochete in it. And you know, this really was the early states, and then it really progressed to be all states. And nowadays, I know it says Nicholas is clear, and 14 it's not now. We see plenty of cases of Lyme from every county in our state, and you can see the exponential, almost asymptotic, anyway, fast rising rate of Lyme disease over time, and it's really just done nothing but continue to explode. And I mentioned it's the white-footed deer mouse that tends to be one of the major reservoirs for the spirochete, and then what's the role of the deer? Everyone always talks about having deer in the yard. They're more a marker of the tick population. So the ticks do feed on the deer, especially the adult ticks, but the adult ticks don't tend to be terrible sources of Lyme because you can see them. You know, you can see them on you and you pull them off before that 36-hour plus time period. Now, so there's been a lot of questions of what changed, what's different, why do we see Lyme now that we didn't see it 10 years ago? And nobody really knows. You know, it depends who's writing the article. Some people say it's climate change. Some people say it's the deer population. I do find it very curious that the Lyme disease incidence and the wet-tailed deer population really mimic each other in our state. So that seems to have some credibility. There's even some talk that it's the bug itself that's changed. Okay, so jumping on to microbiology. Now, so what part do I share with patients so far? I say, I talked to them a little bit about the fact that it's new in the area. So that's about the only stuff I changed now, or I share. This microbiology stuff, I literally am going to share everything I tell you, I share with a patient. Because if you understand this microbiology stuff, it's really going to help explain to the patient what's going on with them clinically and their expectations for improvement. and also kind of eliminate some of their fears. So I always say I'm going to talk science for a few minutes to make you an expert in Lyme so that you can know more than most of your providers do about this bug. And a couple things I share about it. I tell them it's a spiral shaped bacteria. It's too skinny. The reason we can't Gram-stain is it's too skinny for us to take up any stains. We can't see it. So the way we look for it is going to be looking for the shadow of it, i.e. serology. So we can't see it, it's too tiny. A couple bits of information I share about it is that it is a very simple microbe. And there's a rationale for explaining this. And I just put this up here for fun. Look at how simple spirochetes are compared to some of the other organisms on planet Earth. I love this for a couple reasons. Number one, it challenges our dominance as humans as being like the be-all end-all of beings. A newt has me exceeded by 6 times more. Nonetheless, I wasn't born in the water with a tail and then get to, I don't know, it's pretty cool. Newts, amphibians are respectable beings. But I love that flowering plants, even they're the most complex organisms. Sorry, I'm digressing. But going back to the Lyme microbe, it's simple. So why do I mention that one? Because it explains the pathophysiology and sort of also comforts us to some degree. So on the comforting perspective is you do not talk about antimicrobial resistance with spirochetes. Now remember with gonorrhea, you talk about drug-resistant gonorrhea, you talk about chlamydia that's hard to treat, but you don't talk about hard to treat syphilis, right? You don't talk about it becoming multi-drug resistant. Same thing with other spirochetes. They're too genetically simple to have enough genetic repertoire to become antimicrobial resistant. So I don't have any fear of us running out of using doxy or ceftriaxone. As long as we use a beta-lactam or a tetracycline, we're good, okay? Number one. Number two, this is incredibly important. They are too simple to even carry with them the toxins and proteases that normally induce symptoms during an infection. So if we have a strep throat, we have a strep, group A strep sitting in the back of our pharynx, making all these proteins and toxins. And it's those proteins and toxins that literally cause the symptoms. It's the bug causing symptoms directly via its own gene products. And you take penicillin and you feel better in a day. What's different with Lyme is the manifestations don't come from the bug. They come from your own immune response to the bug. So as such, you can take your penicillin, you can kill the bug, but your immune system's response is still going to be present. And the delayed response to therapeutics is because the symptoms are from the immune response, not the bug. I literally explain that to patients and usually use the analogy of the group A strep because most people have had a strep throat at some point in their life. So, and this all comes down to the fact that this is a simple microbe, doesn't make proteases, doesn't make toxins. It's just trying to be a stealth pathogen. It lives inside us as a human. I actually get kind of paranoid imagining life as a spirochete. Like it's a stressful life. You have to like, if you imagine, never mind. I don't want to get too, anyway, I sometimes go there every once in a while. I imagine if I was a spirochete, it'd be stressful. It's almost like you're living in a mouse and then you get sucked up into this incredibly unfriendly environment of a invertebrate that's cold and dark, and then you have to wait until you. But the consequences that actually matter is we can't grow it. It has to live inside another being for us to find it. So the only way we can look for it is serology. So Lyme disease, while I said it's not very respectable in its ability to make proteins and toxins and other things that hurt us, it's incredibly respectable. It's an ability to hide. And it does various crazy things like bind to our extracellular matrix. It can inactivate parts of our innate and acquired immune systems. And it can even do this crazy stuff called antigenic variation, where it can sort of like periodically be like, can change what their outer surface proteins it's expressing might be. How does this correlate with anything clinically that we care about? Well, when we talk about disease manifestations, you'll talk about Lyme disease having flares. You'll talk about an arthritic flare that will come and go. that seems to be likely correlating with these antigenic variations, where the bug literally, just to keep your immune system on its toes, it tries to survive and change up its outer coat every once in a while. It decorates its stuff with different things. And as our immune system recognizes one bunch of antigens on the extracellular matrix, it'll induce inflammation, and we may have a clinical flare, a presentation of acute arthritis, and so on and so forth. So it's all immune mediated. So the natural history of Lyme, I walk a patient through really quickly, and I say, hey, after this tick bit you, it introduced spirochetes into your skin. They proliferated locally, and then your immune system started to recognize those. That was that roundish, reddish rash that you see. But even within 3 or 5 days of having that bite, spirochetes spread out throughout your body and go all over the place. And they can hang out in certain organ systems, perhaps for decades, decade plus. Okay, so pretty amazing. Now, we're not going to let that happen. We're going to treat it and kill it. So, but it's still important to understand that it does disseminate quickly. So this is not just a skin disease. It's not just a joint disease. It's a systemic process that then settles in certain areas. Now, you may sometimes hear patients quote you data that says this is an incurable, your body can't get rid of it. That's not true. In a human, this is incredibly important. If you don't treat it, you will eventually cure yourself. Okay, so that's one of the messages I give people, is people that aren't treated for Lyme disease eventually get over it. And when people produce data that says opposite, it's usually animal data, and that animal data is usually mice. And remember, the natural vector of these spirochetes is mice, and that's true. So the mice can't clear Lyme, but we as humans can, deer can, a lot of more advanced mammals can. So this is a disease process that even if you don't treat, it'll go away. Now you can catch it again, but usually if you've developed a really strong immunologic response, it's unlikely. So say you're somebody who's actually developed Lyme arthritis, and you've got a very, very impressive repertoire of antibodies present, you're probably not going to get this again. And there's good data that says that. It's almost like you've had a hell of a vaccine. You've had natural infection. But if you did just have an E. migrans rash and got treated early on and never formed a whole big repertoire of antibodies, you can catch this again. You can catch it again. It really depends how late it was found and how profound your antibodies profile is. Now, the next bit of information I share with people is this, that Lyme does not kill. Okay, so this is a beautiful case series of almost 100,000 cases of Lyme. And how many people died of Lyme? One. Okay, so out of 100,000 people, one person died of Lyme. And how they died, by the way, was actually during acute Lyme, the myocarditis. So it's really, really rare, but it can happen. So it's really rare. So the message I communicate is a simple bug. It doesn't make antibiotic resistance. Your immune system is responsible for the pathophysiology. It doesn't kill you, and it goes away. So I start the conversation there. Okay, I'm going to skip all this to go to slide 58, because that's
Dr. Gilfus, is it okay if we actually end there so we have time for questions in that poll?
Oh, heck yeah.
Okay.
Yeah. Plus the prevention's cool. I'm going to obviously come back to the other stuff, but yeah.
No, I love it. No, this is fascinating. I'm terrified of any like parasites. I'd rather face a shark, to be honest with you, but that's literally just me. I like that I can see it, punch it, or hug it, whatever. I don't like things I can't,
Yeah.
Ugh. I had a tick on the back of my hair one time, and I felt like a bump, and then my dad just came up almost, I was like, you're going to burn my hair off, and just try to get in there. But
well,
no,
I didn't talk about tick removal, but yeah, we're supposed to just pull them off.
Oh, okay. We'll
Yeah,
get there. But no, this is very fascinating, and it's climbing. You can see cases, I believe, even in Canada.
Oh, it's nuts.
Climate change. It's crazy. It is. It's due to the temperature and rise. So we just keep making it better for them to stick around longer.
I would say 9 out of 10 of our referrals are for Lyme. And rewind 10 years, 9 out of 10 referrals were for Hep C. And so, and this is the power of you guys learn to take care of all this stuff. And my goal is to get your comfort level up from that end too. But yeah, any questions so far about the tick, about the microbiology, the history, or what you want to communicate to patients. Lyme goes away, it doesn't kill you, and the manifestations come from the immune system. And I always tell them, you know, we do treat it. We don't make you suffer for a decade. So we're going to treat you so you get better quicker. And that's going to be during treatment. I'll talk all about that during treatment. So.
Great. Thank you so much. Does
Thanks,
anybody
guys.
have any questions or anything for Dr. Gilfus before we go into the poll? Go ahead, Dr. Leonard.
Yeah, I do need to ask about treatment. So treatment is still doxycycline for everybody. Is that correct now?
Yeah.
Okay.
I'm gonna get out of this thing here. I'll stop my share. Yeah, can you hear me? Yep.
Yes.
So yeah, pretty much the places that you could potentially use Rocephin are for deep and impressive parenchymal CNS processes, where you're too scared to guess. So if you had somebody who had a genuine encephalitis, which is rare, number one. And number two, if you have someone who has literally no response to doxycycline and who has the oligoarthritis, so has a single swollen joint, usually a knee, and doxy doesn't do a darn thing for it, go ahead and escalate to Rocephin for your second course.
Okay.
So
Because
those
that's what I
that's
have
it.
right now.
Yeah.
With a 4-year-old, right knee swelling, 2 months,
Yeah.
off and on. Lyme just came back positive today,
Yeah.
which is what I suspected it would be. So I just started her today on doxy.
Yeah.
So
The only challenge with that one is going to be how long, and I defer this to you guys as pediatrics, you know, your duration there's got to be fairly long. So it is, you know, it's in general, the duration for therapeutics for a genuine arthritis, like an oligoarthritis, is 28 days.
yeah, that's what I did. Yeah.
And so I don't know how comfortable you feel giving a kid 28 days of doxy at that age. I know that they say up to 14 days, there's no worries. And I'm not a pediatrician, so I don't go anywhere. But I'll defer that to you guys. The only reason I would potentially give that person anything different was if you know, you're scared to give them that long a doxy at that age. But,
Not at that dose.
okay, cool. Yep. But no, you're good. And then if it doesn't get better at all, then you could escalate to Rocephin for round 2.
Okay.
Yep. It used to be
Thank you.
round 3. They used to say give 2 rounds of doxy, then ceftriaxone is your third. But really, and I'll get into this when we talk about treatment, but they've sort of changed that up a little bit. And I agree with that approach. If there's really no improvement, you can step up to the IV therapeutics. But if there's some improvement, I just stay put. I sort of just let time help me out a lot.
Perfect.
Great
Thank you.
question.
Great question. Thank you so much. I'll go ahead and launch a poll. Robin has a question. You can keep talking.
I think I might have missed. Did you say how much Rocephin you all end up, like if you're treating with Rocephin after you've done doxy, how many doses? You do 1 gram? How many doses do you do?
Yeah, you have two. If it's, say, if you did it for it depends what your manifestation is. The joint's actually the longest, believe it or not. It's 2 grams every 24 hours for 28 days. If you had somebody that you really had refractory Lyme arthritis, or I should say refractory to oral therapeutics. And I'll talk more about this when we talk about the clinical manifestations, but there's a couple of reasons why people are slow to respond to doxy. And I do drag my feet if there's a little bit of response to doxy, or at least temporary response to doxy, with sometimes a second round of that. But we can talk more about that when time comes. But in terms of dose, it's 2 grams every 24 hours, 28 days.